Testing, testing. Testing. Can everyone hear me okay? All right, good. Good morning and welcome to the Prostate Cafe, our monthly meeting. I'm here to answer all questions for prostate cancer as it relates to prostate cancer to the best of my ability. I want to thank Dendreon as the company that has provided our breakfast this morning, and they have a very interesting product. It's called Provenge, and we do use that here. It is for patients who have what we call castrate-resistant prostate cancer, and the way it works is you would give blood, something we call leukapheresis, and your blood is then sent out to a specialty lab where antibodies and specific molecules in the blood are generated, which are then sent back to us, and we infuse them into you. And we do it three consecutive times, and sometimes longer. But it's very effective, and it's like a designer immunotherapy is basically what that is, and we've had good results. The company has recently published some very impressive results showing a greater than 40% survival in men who really had nowhere to go. So they had no other treatment available to them, and they embarked upon the Provenge, and at a median follow-up, a very long follow-up, they're living beyond 3 years and approaching 4 years. That's impressive. Interestingly, it was actually found to be more favorable in African American men, which is usually the converse of what we hear in prostate cancer. So it's a very interesting drug called Provenge. Anyhow, moving on to questions. Does anyone have any burning questions or concerns at this time? Yes, sir.
Julie, would you mind briefly explaining why you prefer the perineal biopsy versus the rectal biopsy?
Sure. So the gentleman is asking about the two different types of biopsies which are performed. One is called transrectal ultrasound guided biopsies, which is, as it sounds, transrectal. It's going through the rectum. And that is by far the most common form of biopsy that's performed in the United States, primarily because urologists are the ones who typically do prostate biopsies, and that's how they were trained to do it. And I'll try to draw that out in terms of the way it is. The prostate gland shapes something like this, and of course this is a big magnification, but the rectal wall sits in the back of it. And well, this right here would be considered the anus. And what happens is a probe is placed into the rectum, and through that probe, needles jettison out and sample tissues in the prostate. Okay, and hence transrectal ultrasound guided biopsies. Here is the ultrasound. These are the needles going through the rectum. Now, there are 4 major reasons why I don't do it that way. And instead, I do it through the perineum. But first, let me tell you more about the rectum. So the rectal wall has bacteria in it. It always will. I mean, you could do a bowel cleansing, you could do Fleet's enemas, but you'll never make it sterile. And because of that, 100% of the time that transrectal biopsies are done, you are introducing bacteria from the rectal wall into the prostate. And as I tell people, however, would you expect 100%, infection rate? No. Just as if we're in a room filled with 100% of people having COVID, we may get it, but that number is probably 15 to 20%. Similarly, patients who have prostate biopsies through the rectum, about 15 to 18% end up with a urinary tract infection, and they end up in an emergency care, an urgent care emergency room within 36 to 48 hours. Now, 5% of them actually end up in the ICU, meaning it becomes a bloodborne infection. So that's kind of a big deal. Second thing is many men who have prostate cancer or undergo prostate biopsies have an enlarged prostate. And if there happens to be targets in this area here that we call the anterior zone, it might be very difficult to get to your targets because, again, you got to traverse the rectal wall. There's actually a fat plane, which I'm not showing you here, but then to get to these spots here may be challenging. The needles that come out of that ultrasound probe aren't that long. And so that's one of the other big issues. Another issue is that the rectal wall has a lot of big nerves, and they cannot be avoided with a transrectal ultrasound guided biopsy. It just has to happen, and you're going to hit those nerves. Now, hopefully, when it's being done, you're anesthetized and you don't feel it. But when you wake up, you will, and it could be a throbbing pain. People tell me for 10 to 14 days, it's very, very uncomfortable just because you can't avoid the nerves. Finally, there's also a lot of vessels in the rectal wall. And by the way, there were nerves also in the prostate, but they're smaller nerves. And there are also vessels in the prostate, but they're smaller vessels. But the ones in the rectal wall are very big. And you can't help but avoid them. And when you do, there can be more bleeding associated with the procedure. There has been a sizable amount of data in literature suggesting also that patients who do have the transrectal biopsy approach actually have a higher rate of dispersion of cancer if they have cancer harbored in the prostate. So it appears to be that the commingling, of the prostate where there might be a tumor and then pulling it out, that could actually commingle the blood with the cancer and disperse it. Now, that's a small number. It's not a big number. And I don't discourage men from getting it because of that, but it's a real number nonetheless. And, if it can be avoided, it, hopefully could. Now, transperineal goes through an area we call the perineum. And the perineum is right here, and it sits between, the scrotal sac and the penis. And because it is skin, we can sterilize that. Okay, so the risks for infection are next to nil. Okay, and that's a very important aspect of it. Similarly, in contrast to these kinds of biopsies, we can go anywhere. There's no place that I can't get to with a transperineal prostate biopsy. I also have a probe in the rectum, by the way, but I'm looking at the prostate. I'm not jettisoning needles into the prostate from that probe. Thirdly, the nerves in the prostate can still be engaged, but they're smaller nerves. And we do anesthetize you during that procedure with twilight anesthetics, very similar to colonoscopy if you've had that procedure performed. And then what I try to do is at the very conclusion of the procedure, before you wake up, I do a nerve block. And that really does take care of the majority of the pain. So there's very little pain associated with it. And then finally, the bleeding aspect is far less. And the reason being, again, the vessels in the prostate, while they're plentiful, they're smaller. And what tends to happen is the urethra, which runs down the prostate, if there is bleeding, it migrates over to the urethra, ends up in the bladder, and then you just pee it out. So it's a closed loop, and no one has ever documented a single case report of a patient having transperineal prostatic biopsies compared to the transrectal ultrasound. So for all those reasons, I'm not a big fan of the transrectal, but it is a way of, getting information about the prostate if there's cancer, but I favor the transperineal. Okay. Anyhow, any other questions?
In other words, in your opinion, you're saying not only the procedure part, but the results are better on the transperineal than the on your choice. The results are cleaner and better.
Yeah, so he's asking, are the results with transperineal better? And I think they are, for the reasons I've told you. I can get to locations that you just cannot get to. Now, if you happen to have a small gland, you probably can get to all the spots or targets that you wish to get to with a transrectal probe. But if your gland is larger, that could become an issue. And it really has a lot to do with where the location of the tumor is. Is it on the front? Is it in the back? 'Cause if it's in the back, you can get to it. But if it's in the front, it's problematic. There's another area called the transitional zone, and that's very problematic to get to. But it has to do with the largesse of your prostate gland. Generally speaking, before a patient has a biopsy performed, an MRI is done. And that's become fairly common now, I'm glad to say. And MRIs have gotten really good in terms of delineating cancers in the prostate. It wasn't that long ago that an MRIs didn't tell us a whole lot. 10 years ago, the radiologist reading them would say, well, I think there's a cancer. And that's what they used to tell me. And then what happened is they started upping the ante in terms of the strength of their magnets. And as they went up and up and up with the magnet, it started giving them better results. And the reason being is that the prostate's a moving organ. It just moves all over the place. And if you've had MRIs, they're typically designed for things that are static, like your spine, your neck, your long bones and your legs or your arms. Not so much if things are moving. Okay, you can't do an MRI of the chest because the cardiopulmonary, motion is just too great. But the prostate also moves a lot, and they found that if they can get up to a 3 Tesla magnet, it's called, then they can get pretty good imaging. And when they started to do that, they started to become far more definitive in saying, "Oh yeah, there is a cancer there." Okay, and they really, they kind of hung their hat on that. More recently, when using something called multi-parametric MRI, which is a different way of reviewing a whole bunch of parameters that the MRI is using, they can now say not only we think there's a cancer there, or we know there's a cancer there, but we're going to forecast or predict just how aggressive the cancer is going to be. And they have a scorecard. It goes from 1 to 5. It's something we call PIRADS scorecard that the radiologists use. And with 1 being the best, 5 being the worst or the most aggressive or biologically aggressive. And so that's what they do now. So typically when we order an MRI, because you may have an elevated PSA, and we get back the report and then review it, it'll often say there is a cancer or a mass at this location, and we assign it a PIRADS of 2, 3, 4, 5, whatever they see. And I do a lot of biopsies, so they're typically right. They can be wrong, but they're typically right. So for that reason, we like MRIs. And what we do here is we import the MRI images into our biopsy system. So it goes into our computers. So there's really no guesswork, in terms of where the mass is. When I do a biopsy, it's fairly clear. The problem with that, however, is that again, the prostate moves, and so do patients when you're doing a biopsy. And the MRI, information that we have may show you a XYZ coordinates where you want to go. But then what happens is the patient coughs or he moves or he wiggles, and suddenly your coordinate system is off. So what we do here is we use yet another instrument called a 3-dimensional color flow power Doppler ultrasound. And it's a very exacting test as well. And I believe it's complementary to the MRI. And the advantage of that is that if you move, it's not a problem. We move with you because the ultrasound can move with you. It's live, it's real time, whereas the MRI is fused with previous data, a previous data set. So that's what makes, I think, our procedure really nice, and that we do it transperineally, and then we do use a 3D Doppler ultrasound to guide our needles. So having said that, I do believe that from the standpoint of what this gentleman asked, is it better? Well, yeah, better for the 4 reasons I showed you, but probably better also from a cancer diagnostic, or let me say cancer yield perspective, with less false negatives. Okay.
Does
Yes.
the PIRAD score show
So she's asking if the PIRADS shows lymph node involvement, and it does not. Typically, an MRI is okay at picking up lymph nodes, but again, the prostate's right in the middle, okay, and we're using the Tesla magnet. The prostate moves a little less than the surrounding areas, which move a lot because they have bowel moving around them. And so lymph node pickup can happen with an MRI. And often you see it when they're close or very nearby lymph nodes that we call internal iliacs, obturator lymph nodes. They're very close to the prostate, but if they get removed, it's not so good at picking that up. There are other tests that we use. But again, if it's a periprostatic lymph node, meaning it's close, then the MRI can show it. But one of the problems with prostate cancer is, yeah, it goes to lymph nodes, but it doesn't typically make the lymph node that big that it can be picked up, because lymph nodes are, they're the drainage system, of the filters of our bodies, so they're moving and they're constantly moving, and so it may pick up a lymph node, or let me say the cancer may be found in a lymph node, but then it moves up to the next station. So they never get too big, although they can. And for some reason, they just stop in an area and you get really big and large engorged lymph nodes. But for that, we use other tests like a PSMA PET scan, even a CAT scan, like a light speed diagnostic helical CAT scan may show more information regarding lymph node dissemination than an MRI does, but it can. And MRI can also maybe comment on some of the bones of the pelvic area in the event that there is spread to bones, in the hip areas or in the iliac bone or things like that.
What's your approach to an aggressive cancer that has metastasized?
So the lady is asking our approach to cancers which have spread, which classically are going to consider stage 4. It's gone to the bones, and unfortunately, a lot of oncologists they say, well, it's spread, cat left the bag, the horse left the barn, game over, and that's unfortunate. Now, the reason why that is because chemotherapy doctors, and there's a lot more of them to me, okay, they think that way. Their chemotherapy doctors are used to giving agents in the blood which are considered systemic. It works throughout your body. So that's just how they think. And since there are a lot of them, a lot of times, patients are very distressed when they come back from that doctor telling them, who I'm an oncologist, they're also called oncologists, but they'll say, well, it's gone. We can't do anything. We're going to give you some hormonal agents and be done with it, or we're going to give you chemotherapy, which I'm not a big fan of. But here we approach it a little differently. And our thinking being is, first and foremost, the cancer began in the prostate, okay, in that region of the prostate. And there's a lot of data and evidence now that it's very important to take that cancer of the prostate and get rid of it. Because if you don't, it's going to continue firing off and sending cancer cells elsewhere. And it's going to do that more than any other place. So if a cancer goes to the bone, it's going to stay there for a while, but it's not going to stay long in the prostate. And so we're big believers in a statement that I often say, and that is putting the fire out where the fire started. And we feel that if you want to get control of the cancer, you have to do that. And we're always looking at the primary. Now, there's other sites of the body that are doing that and making the case that you have to eliminate the primary site. Otherwise, I know I often talk about it being the conductor of an orchestra. The orchestra being out here, the trumpets and violin, they're out there, and the prostate inside it is influencing what's going on out there. There is data under a catchment of a word called abscopal effect. And what it means is that if you get rid of the primary site, other cancers just wither and die. And the two areas, well, there's actually 3 now that are known where that happens. The prostate cancer is one of them, melanoma is another one, and renal cell carcinoma of the kidneys. So we call it the abscopal effect. And so what we do here is we make sure that we treat the prostate, and just shut that down. And in addition to that, again, those lymph nodes that I described, which are close to the prostate, they tend to be the same. So they're the same cells. So we got to put those out too. And finally, as it relates to bones, we try to do a couple things. If there's a big bony lesion, if there's a mass in the bone, uh, we shoot at that too. We put that out too because it's volume. It's macro metastatic. It's not just small disease; it's larger disease, and that appears to be important. We also use agents which specifically target the bone. So, for example, bony cancers associated with the prostate use a specific enzyme in the bone we call RANKL enzyme. And the RANKL enzyme is what cancers of the bone use to grow faster in their bone, but also to spread to other bones. So we use agents. One is called Exgeva, another is called Prolia, and we give those sometime prophylactically, but in patients who have cancer spread to bone, we use it all the time. We start off by using it as a monthly, it's an injection, and then we go to quarterly thereafter. But it really does stem the tide in terms of the growth of cancer in the bones. We also use some other agents. One is called an estradiol patch, and it's kind of a multifaceted hormone. We use that to lessen hot flashes, which men get from hormones, but we also use it because it has a direct input right at the level of the bone. And so by doing all those things, it's treating the bigger picture or the whole picture. We don't like to just say, "Oh, we're going to treat systemically, we're going to give you these agents," because if that's what happens, the first area that typically becomes a problem for the patient is the prostate. Okay. Not only was it influencing cancer elsewhere, it's going to create problems in and of itself. And it really does sit in a precarious location where it can block things off. It can block off the urinary system and the urinary channel, and then you can't pee, or you require a catheter, or it blocks the kidneys higher up, or it can block the rectum. So for all those reasons, and cause a lot of painful symptoms. So for all those reasons, we do treat the patient with a faceted approach. Yes, sir.
Use targets, gold targets.
Yeah, so the gentleman's asking if we use gold targets, and we do not. I used them like 20 years ago. They're called fiducial markers, and you put them in there, and you have ways with orthovoltage on your linear accelerators, the actual treatment with radiation, to image the gold marker seeds. The problem that I see with that is, number one, it can add artifact to other types of images that you get. I also use seeds, brachytherapy seeds I use a lot of, but the ones that we use are non-ferromagnetic. So they're, graphite, and they don't interfere, but the gold markers can create a fair amount of artifact. We have very advanced radiation targeting system, and we just don't feel it's necessary either. So it's just one less thing that we use. Yeah, so he's asking about a rectal blocker. It's often referred to as a rectal shield, and we do use that. Okay, and what you do is you basically put a hydrogel material directly at the level of the rectum and the prostate, so it spaces those two out, and that can be very advantageous. We especially like it in our patients who have brachytherapy performed because of all times when radiation is going to be closest to the rectum, it's then, because then the prostate is sitting on the rectum, and it does space that out. So we do use it, but I think that's very, very advantageous. There are different types of agents. One is called Spacor, another is called Barrigel. We like the Barrigel, but I've been using that for a long time. Is there a urethral shield? Is his question? Unfortunately not. Okay, that comes down to really special type of radiation. So let me give you kind of so the prostate is shaped something like that. And, we often talk about it being like talking the prostate of a small fruit or a kiwi or a walnut, when in reality, it's like a heart. And the bottom is called the apex and the top is called the base. And then it has a right and left side to it. And then the prostate urethra, which all your urine has to go through, goes right down the center. Okay. And so while I can't show you the rectum on this, pictorial because it's behind the prostate, but this is looking at the prostate straight on. And well, when you treat with radiation, typically in most places will treat the prostate in its entirety. So they'll say, well, we're going to give a uniform dose to the prostate. Okay. And that's the way it's done. So you say, well, it's going to get the dose max, which we prescribe, and the whole prostate's going to get that dose. And that's effective and it works. The problem with that is the center will also get the D max, okay? And that's where most of the symptoms come from with prostate radiation. So, in contrast to that, and what I do is I say, okay, well, there could be cells that we don't even know about elsewhere in the gland. So I certainly, and you can't see them because they're microscopic. So the thinking being is, well, I better give what we call a microscopic dose to the whole gland. But when it comes down to the definitive doses, that isn't necessary. So if there's a tumor here, I'm going to give the tumor a higher dose. Okay, so wherever the tumors may be, those areas are going to get the higher doses. And I'm going to accomplish that with the external radiation that we call DART. And I'm also going to accomplish that with the brachytherapy. Interestingly, there are also styles of brachytherapy. And one style is called uniform seed placement. Okay, and what it basically means is, as it sounds, we're going to put seeds uniformly. What it means is every seed is equidistant from the other seed. Okay, and you do that throughout the gland. Well, if you just think about that picture, if you happen to be sitting here, you're going to get a fairly high dose from the brachytherapy. And again, that's the area that causes most of the problems, the urethra. I often talk about it being like, if you had electric heaters, you're putting a lot of electric heaters in there, and where's going to get the highest dose? Right in the middle. Okay. And if you look at data of uniform seed brachytherapy, which also is a more common way of doing it, the dose to the center urethra gets almost 16 times the dose of over here, the outskirts, which is not what you really want to do. So if you think about that, if you were to just place seeds inside the tumors and then some seeds like this in the periphery, well, again, if you think about it, and if you happen to be sitting here in your room and you're surrounded by electric heaters, you're still going to get a pretty toasty dose in the middle, but not 16 times. Okay, so for that reason, I favor something we call peripheral seed loading. Okay, with the brachytherapy procedure. No, so he's asking why not put like a sleeve or a barium solution. You just can't do it, and the reason you can't do it is because, first of all, this is 3D. Okay, secondarily, because you may have cancer cells sitting right there, and often you do. Okay, and they may be microscopic. You can't see them, but you're leaving them alone. So you've treated them. You treated the rest of the gland, but you've avoided. And what'll end up happening is you'll start seeing recurrences in a periurethral location. And so it makes sense just to treat it to a microscopic dose, though, because that tends to be acceptable, associated with less side effects, and then you boost other areas to higher dose levels. Yes, sir.
The procedures you're talking about are done in this building or someplace else?
So he's asking where the procedures are done. So the external beam radiation is done on the other side of this building. Okay, so we consider this side of the building our diagnostic section, and the other side the treatment section. Okay, and so for those of you who are on treatment or have been treated here, you know that you kind of come over on our side, which we call the clinic. And then after you're, in the clinic, you go over to get your actual treatment on the other side of the building. Meanwhile, the brachytherapy, that is done here. And we do it on the second floor on the other side of the building, where we have a procedure room. And that was actually a big deal. I think we're going up on a year having had that, because I used to do my brachytherapy procedures in the hospital, but I now do them right here, and that just makes it so much easier for the patient. And it has a patient in and out in no time. So we kind of just do it, and then we have a recovery room where they stay for about 40 minutes and then start working their way out of the building.
Biopsy procedures are done here.
Yes, and so also the biopsies are done here as well in that same procedure room. So, for example, yesterday I did a bunch of brachytherapy procedures and as well as biopsy procedures.
The other question I have, I assume that current insurances, your facility is participating so that Medicare or extra coverage like Federal Blue Cross Blue Shield are within your areas of receiving funds.
Yeah, so he's asking about reimbursement. Who pays what? I don't know. I have a section that takes care of it, but generally speaking, my people tell me Medicare is the best. They pay for everything. That's what they tell me. And then, PPOs are next in line, and HMOs but that goes with just about all medicine. So generally speaking, though, it's not, what we do here is not considered experimental, even though we do some interesting things, which are different, but we don't charge it any differently than any other place.
You're an approved insurance facility.
Yes, he's asking our approval. We are an approved insurance facility for sure. Yes. Okay. Any other questions? Okay,
I have
well,
one more quick one.
yes.
So if I was considering to have a surgery, what's the timeline that you usually have?
So he's asking timeline. I don't do surgery. I used to do surgery called radical prostatectomy, but here we do radiation treatments, both, radiation of the external variety, radiation of the internal variety. We also use infusion types of radiation, and we do immunotherapies and all kinds of other things, but we don't do surgery. Is that what your question is, or are you just asking how long to get in? Or yeah, I don't know that. I leave that up to my people in the front office to me. That they would tell you better than I know. Okay, I know we're very busy. I do know that.
Yeah.
Yes, sir.
This is actually not a question.
Okay.
But I'm near the end of my treatment, and if any of you all are trying to decide whether to go this route or maybe a full-on just remove the prostate, I have met numerous men at this facility. I started last fall, actually, but that were here after they had already had their prostates removed, and several of them were in big trouble. I mean, it's there's actually, you could probably explain why cutting it out is not a great idea, and particularly since I'm aware that Dr. Dattoli's, a lot of his patients are here that have already been treated, already had their prostates removed, and they still have prostate cancer. And I believe that you can explain why that is.
Yeah, so he's asking about really treatment options, associated with prostate cancer, and why we do what we do. My focus is radiation, but I used to do radical prostatectomy, and I think most men are told, you have prostate cancer, get rid of it. It's one and done. You're finished. You don't have to deal with it again. And that's what most urologists tell you. And in fact, many urologists will also say, you should have your prostate removed, because if you have radiation, we can never remove it again. That's a myth. but it's been working for them for 25 years, and they continue to push that myth because it really does work. It's a scare tactic. Um, Again, I used to be involved with radical prostatectomy, and the most newest way it's done, called Da Vinci robotic procedure. And prior to which, I was doing other cancer surgeries, and I came to learn some different things about cancer surgeries. One of which is, this is a cancer. You may feel it like a lump, a bump, a nodule. You may see it on a scan like a black spot, a marble, a stone. But when you remove a cancer, and you can look at this anywhere in the body, lung, tongue, brain, breast, gynecologic, you don't just remove this. And the reason you don't is, even if it looks like it has very well-defined borders, you know that this is going on. And they're typically microscopic. You cannot see them. That's the nature of cancers. What makes a cancer is its ability to grow faster than the parent cell. If this is a breast cancer, faster than breast cells. Prostate, faster than prostate cells. The second principle is that it can send its little feelers into the tissues around it, invading surrounding organs, and that it does also microscopically. And then the third thing, it gains access, or can gain access, to the vascular network and spread throughout the body. But when you do a cancer operation, wherever it may be, you realize that principle, that cancers are likely here, but you can't see them. So you take out a big chunk. That's how you do cancer surgeries. And you could typically do that. If you had a lung cancer, you could take out a big swath of the lung, maybe a whole lobe. Liver cancer, the same. Breast cancer, tiny tumor the size of a BB, you still take out a lemon to make sure you've gotten these tentacles out. But you can't do that with the prostate. Now, again, I showed you a side view of the prostate biopsy picture where the rectum sits right behind it, okay? But there's a lot else going on with the prostate. So right here is a very big valve that we call the internal sphincter. And it's a big muscular valve, and it's actually part of the bladder, which is bigger. But it's the very bottom of the bladder, the very top of the prostate, has a big muscular valve. It's only big and thick right here at the bottom, but it's the control center for urination. So men rely on that. They've relied on it their entire lives to control your urine. When you got to go, when you feel like you got to go, it's all because of this big sphincter muscle. And when you finally release, it's because you open it up. Between the prostate and that bladder are these appendages that we call seminal vesicles, and they're basically the reservoirs for seminal fluid, which the prostate makes most of. So the prostate makes most of the seminal fluid that we know as the ejaculate, and then stores it in these appendages just above it, called seminal vesicles. But if you had urine in your bladder and you say go, you'd open up the big sphincter and it would go right down the center of the prostate and then exit here. There's another group of sphincters right here, but they're just below the prostate, but they're smaller in comparison. They're part of what we call the urogenital diaphragm, and which is affixed to the bottom of the prostate. Meanwhile, you have nerves, arteries, and veins running like this. We call those the neurovascular bundles. And again, continue with the urinary tree, it eventually goes out and, goes to the penis. But these big nerves, arteries, and veins are going to nourish the penis for the erection. The prostate is a sexual organ. That's what it is, pure and simply. It makes most of the ejaculate. I've told you, it's actually considered the G-spot in men. It has a lot to do with the orgasm, and then carries the nerves that go to the penis. So, but it's a busy location. And again, on this particular front view, I can't show you the rectum behind it, but think about this. Most cancers of the prostate do begin along the edges. And we call those edges the peripheral zone. They don't commonly begin here, here, here. They may microscopically, as I was describing, but the bulk masses or tumors typically begin along the edge. One of the interesting factoids about the prostate, and you can Google it, is it does not have a capsule. Most organs in our bodies have capsules. Just about everything in the urinary system does. Even the testicles and the penis have capsules. The prostate doesn't, and yet the cancers are right on the edge. So what they do is, they can pretty much send their little feelers inward, and they're going to do that easily because of the nature of the prostate tissue, but they also do this fairly easily. And that's a problem. And if you just think about this picture and put it in the perspective of what I showed you with a tumor, how you typically go wide around it, well, how are you going to do this here? Are you going to go like this to get all those tentacles? Well, if you did that, you'd end up in the ICU for a long time, healing because your rectum has been removed and a bladder. No one does that. So the way prostate surgery is done is it's peeled off of the surrounding structures, and you basically just come around like this. If you happen to know there's a tumor there, you can go a little wide, a little wider, if you can feel that tumor, but there's only so wide you can go. And then you come around and you come around, you try to take out those reservoirs because cancers can go to those. And then you have to take out that big urinary valve called the internal sphincter, and then you come around. Well, if you just think about that picture, now I'm without a urinary valve called the internal sphincter. So issues which are really important, become incontinence and leakage, and they don't get better. They tend to get worse as we get older because now you have to rely on the smaller sphincters below the prostate called the external sphincters because they do remain. And that's where all the control now after the radical prostatectomy has to be. But, and of course, sexual function is pretty much gone. When I was doing that procedure, I fully expected men to have issues with leakage, incontinence, and sexual dysfunction. But what I didn't know is just how many men's PSAs were going to be rising again. And that's when men are shocked. They're like, what happened? How can that be? Why is my PSA going up? I had my prostate removed, and it's just the prostate that makes the PSA. Well, because there's likely some cancer cells left behind, so, just like in the picture I showed you where there's a tumor here, and if these are going out like that, well, if you did that, you left some of those tentacles behind, and it only takes one cell to recreate the whole problem all over again. And in those men, they finally find, okay, now I actually have to undergo radiation again, or in the first go round, maybe if I had chosen it from the beginning. So having said that, I'm not a big fan of radical prostatectomy. If it was the best thing in terms of cure, I'd still be doing it, and I'd be telling men they're going to have to suffer incontinence and sexual dysfunction, but it's just not. And then you could look at the data. I became an absolute data hawk on that when I was doing the radical prostatectomy, and I realized, it was a significant failure rate associated with that procedure that is not told to you by urologists. And again, there's a lot of urologists out there, and that's what they do. Just as, and again, this is what they do. This is what they've been taught to do. So I can't fault them. Just like they do the biopsies through the rectum because that's what they're trained to do. And so they're trained to do that, and but it often leaves a problem. And one of the other things is when you remove a cancer, you try to really make it a bloodless operation. You don't want to spill blood, but if you look into prostate surgeries, radical prostatectomy, fair amount of blood lost, and there is data suggesting that when you do remove it, there's cancer takes off and ends up liver, lungs, bones, things like that. So that's a big deal too, and that's in the data. It really is. So anyhow, I'm not a big fan for radical prostatectomy, but it is an option. It definitely is a treatment option in men. Yes.
After, let's say, treatment, radiation, do you expect the PSA to go down and stay down, or monitor it for forever?
Yeah, so he's asking the question of after radiation, what do you expect? Well, we do expect a PSA to go very low, okay, and then it typically stays low for a long period of time, if not forever. Under 1, in ideal worlds, even less than 0.5. There is a group of men who do have something we call benign PSA bounces in the first couple of years, where you have no idea why the PSA is going up, and but then it comes back down, and it's called a benign PSA rise or a benign PSA bounce, but it's not in everyone, but it's a real phenomenon. But generally speaking, after radiation, the PSA goes down, and it rarely comes back up again because you've killed the cancer, okay, and the cancer was making most of the PSA. Meanwhile, the prostate has shrunk. So radiation does shrink your prostate a lot. So it takes men who have very large glands that we call benign prostatic hypertrophy, BPH, and it brings it down to a smaller size, and it really remains that smaller size for a lifetime. You know, I follow patients for a long time, decades, and it really does. It's stuck at that size and it just stays that way and it doesn't grow again. So, but a low PSA is what we expect. After surgery, you expect 0. Okay, but that's rarely attained. Also, I think that another thing that's underappreciated is men who have their prostates removed surgically, called radical prostatectomy, there's still prostate tissue left behind. No one has ever done a complete radical prostatectomy. Okay, and that's another problem because you just think about that. You know, if you leave any prostate tissue behind, and I've already told you there was microscopic cells happening around the gland. So now you've removed the prostate, but you left some prostate tissue, which has been subject to, you know, your genetics, environmental cues, your diet for a lifetime, and over time they morph and become malignant because they were left behind. And so for that reason, you also see late failures. You know, so you're kind of never out of the woods. You know, I've treated men who've had their prostates removed, you know, 25 years ago, and it comes back. You know, yeah, yeah, that's not so common, but I have, and you know, I'm almost always have someone on treatment with PSA coming back 10 to 20 years after their prostates are removed. You know, but more commonly it would come back within the first 5 years. Okay,
Sorry for another
it's
question.
all right.
As a gentleman, I am
Yeah.
mid-80s, and the PSA is on to 10. Do you worry about it, or just take it and let it be on its own? Sooner or later, something's going to happen when you're 86. In 1 year or 10 years, who the hell knows?
So he's asking about basically when are you concerned about a PSA? Okay, that's a kind of the broader picture. Okay, so here's the thing. PSA is a number, okay, and that's all it is. And we're less concerned with a patient who has a number like 10 if it's been 8 or 9 or 11 for a good number of years, okay? Or maybe it's just been very slowly going up from 7 or 8. Because after all, normal prostate tissue, normal prostate cells make PSA, okay? That's what they do. And so what happens is as your prostate gets larger, as it tends to do as we get older, there's more tissue to make PSA so that you actually end up having a higher PSA number, okay? 10 is high, though, I must tell you, okay? I mean, that does get my attention. It's kind of a magic number of 10. Actually, 8 gets my attention, but not to scare you. But generally speaking, there's something that we refer to as PSA kinetics. And what that basically means is what is the rate of the rise? And we refer to that in oncology as the PSA velocity. Okay, so how fast is it going up? That tends to be a lot more important than what the absolute number is. So, for example, if it's going from a low number like 0.2 to 0.8 to 1.4, that's more concerning than a PSA that's 5 or 6 and has been hanging around that number. Okay, because it's showing some changes, and those changes are happening faster than we would have expected. There's a general rule of thumb, and that is it shouldn't be rising more than 0.5 to 0.75 per year. Also, the doubling time should not be less than 12 months or less than a year. Okay, so that if it goes from 1 to 2.2 in under a year, that's also concerning. So that's something we look at, PSA velocity. There's also something we call PSA density, and it's a number, and what it looks at is what is the prostate volume, how big is it, and then what's the PSA, and you basically do a PSA divided by the number of the volume, and it derives and you get a number. And if it's less, if it's less than 0.10, it's fine. If it's greater than 0.10, then it's concerning, and we have to pay attention to it. And that's called PSA, not doubling time. It's a PSA density. And there are other things that we have to look at, one of which is, here's your PSA. There's another number that you may get with a PSA if any of you are just following a PSA. What is the percent free PSA? And that's another number that's derived at a laboratory. LabCorp, Quest will do that. And that's an important number because the lower the percent free PSA, the higher the probability that there's cancer. And of course, along with that, we have to take into account other things, like, do you have family members who've had prostate cancer? Okay, that's very, very relevant when we're looking at an elevated PSA. You know, if you've had none, that's important from the standpoint of maybe we're, saying, okay, not so high probability. There's other cancers that are also integrally related to prostate, and those include in women breast and ovarian cancer. So I often ask men whose PSAs are rising, do you have any on the female side, any members of the family who've had breast or ovarian cancer? Because that also independently puts you at higher risk for harboring a prostate cancer. Pancreatic cancer is powerful. So a first-degree relative, and that could be, brother, sister, father, mother, who've had pancreatic cancer, again, puts you at a higher risk for harboring a prostate cancer. So those are called PSA kinetics. And then there are other tests along the way that can be done. For example, there's something we call a 4K score. And this is for men who, we don't know what they got, but their PSAs are rising. And it's another way of forecasting the probability of harboring a prostate cancer. And we do use that. As I was saying earlier, more commonly now, and I think it's been pretty well accepted in the community, is that most men who have a rising PSA or a high PSA will get a good multi-parametric MRI with a 3 Tesla magnet to say, okay, this is what the gland looks like. Prostate cancer, this 2026 is believed to be the #1 cancer diagnosis in men in the United States and perhaps the world. So it surpassed breast cancer, okay, and lung cancer and colorectal cancer. There's a reason for, I don't know the reason for that, but it's happening. It's part of the data. Also, and it's been a steady 3% per year since 2010 increase when most cancers are on the decline. The other thing is we're finding that most men having prostate cancer, it used to be everyone having just localized prostate cancer, low grade, low volume. Not the case now. Now more and more men are presenting with advanced disease, so that even at an age of 80s, you do have to pay attention to it, and you have to also say, okay, do I have other comorbid medical problems competing with my life? In other words, do I have significant heart disease, lung disease, uncontrolled diabetes that I have to be paying attention to, because those things may take my life sooner. Okay, but you just never know with prostate cancer. It's kind of a sneaky disease, and since it is increasing in incidence, is increasing with more advanced stages presenting, it's, I think most men should pay a little more of attention to it. I think that's maybe one of the reasons why it is growing, because there was a period of time a lot of men weren't paying attention to it. And there was a task force that happened in 2009, and they really lessened the need for doing PSAs. And for all I know, that's what's catching up to men now. I don't know, though. It was a long time ago. It could be a virus, making more prostate cancers more aggressive. I don't know.
Is there a specific test that you have for the free PSA as a normal Quest diagnostic test for PSA?
He's asking about the type of PSA testing. I would recommend, it's called total PSA with percent free PSA, with the overall number of free PSA being the important number. I mean, total is good too, important too. But if you got a total that's moving up or high, and you got a free PSA that's low, those are concerning. Okay.
Would you repeat that again? PSA with?
So it's a total PSA with a % free PSA is what it's called. And all the labs do that now. Yeah, they do it. All the laboratories do it.
My test results.
No, not necessarily. It doesn't have to be there if it was ordered that way. So what I'm saying is most labs will do it if it's ordered that way. Okay?
So free PSA is more indicated.
Yeah, so the lower the % free PSA, the higher the probability of prostate cancer. Mhm. Lower, yeah. Typically, like if the % free is 14 or less, then it's more indicative of cancer. And then if it goes from 14 to 10 to 8, one of those real low numbers, oh, then it's a pretty high probability of prostate cancer.
Free PSA.
Yeah, there's a lot of, it's a confusing topic. There's a lot going on to know
Free
about.
PSA. Is the ratio of the normal PSA to the free PSA?
It is. It is. Yes.
I noticed that you have some supportive supplements. Do you also include any nutritional like needs, ozone, or either vitamin C?
We don't, though. I'm not opposed. She's asking about supplements and other types of agents out there, which I'm open to, and I'm not opposed to it at all. I know there have been some recent studies, with IV, vitamins showing distinct advantages with cancer. Not only prostate cancer but other cancers. So, there's a lot of things out there that can help. Certainly diet is an important component to prostate cancer and other cancers. Cancers thrive in an inflammatory background. They love inflammation. And in fact, there's a test that's called, again, most labs will do it, just your doctor has to order it, called C-reactive protein. And that test tells you exactly what your inflammatory burden is in your body. And whatever it is, it could always go lower, so doing things that have anti-cancer effects, be it diet, be it ozone, be it vitamin C infusion, they'll lower the inflammatory burden. And that's all a good thing. Just like, extra virgin olive oil is going to lower your inflammatory burden, as will avocados. We say an avocado a day keeps the doctor away now, certainly the oncologist away. It had, but all, most diseases, it's not only cancer, but heart disease and diabetes, everything is kind of promoted by inflammation. So we do recommend a good diet. The two big bad ones, if you look at data, and I do, and that is red meat and pork tend to be the big, creators of inflammation. It's just those saturated fats. And of course, you got all the processed foods that we have so commonly in our diets, and then you have the ultra processed foods. You have your bacon and your cold cuts. I mean, they're bad. Yes.
I wanted to ask you, I'm glad you're talking about the diet. Is there truth to the fact that that sugar necessarily feeds the prostate cancer? I know sugar is a major inflammatory substance, but or am I wrong in thinking that prostate cancer is more of a hormonal testosterone feeding
Right.
influence?
So she's asking about prostate cancer and sugar. And that's very interesting. Most cancers, just about every cancer in the body is fed and promoted by sugar. Okay. And prostate is not. When we do scans called PET scans, generally speaking, if you had a tongue, lung, brain, breast tumor, we would infuse you with sugar and then, several minutes later, scan your body to see which areas of the body took up that sugar. Okay. And that's because cancers feed on sugar. If we did that to prostate, it would show nothing. Okay. And that's very interesting. Now, having said that, just as you said, but sugar does promote inflammation. So, it's still going to happen, that it's not a good thing, but it's just not a direct feeder of prostate cancer. But we're big on, we think supplements are really important, and most supplements that we recommend, do have anti-inflammatory properties. And the others will have immune enhancing properties. Because again, cancer, it if a person has cancer, it's because their immune system failed them. I mean, there are other reasons, but certain vitamins and supplements do, help your immune support. So we promote that as well.
I guess prescribe like hormone back before radiation, so many months before radiation.
He-
Cancer.
Yeah, he's asking about hormonal therapy. Orgovix is one of them. There are many, and that's under a catchment of what we call primary hormonal therapy, which basically means that it's creating an environment of low testosterone. It's the male menopause, taking away testosterone because testosterone feeds prostate cancer. Every patient here is individualized with respect to that. Okay, I don't always do it. Sometimes I do. If we do it, we do it more during the radiation because that's what the data supports. And I've looked at it, so many studies doing hormones before and during and after, just during, just after. And when you look at that data and break it down, it appears that it's the during. And that makes sense because there's a growth, cancer, as I mentioned, they're growing faster and they're going through this growth cycle. And it just so happens that a certain part of that growth cycle, they're more vulnerable to the radiation hits. And it just so happens that primary hormonal therapy puts them right there. And so we call that a sensitizer. Okay. But in some people, we don't use it. We try to, it's a balance because they do have side effects. There's another, a whole nother world that we're using more and more. It's called next generation agents because while primary hormonal therapy, and there is definitely utility and value to it, and it's necessary. But it's more entire body in terms of shutting down testosterone, whereas some next generation agents, they don't shut down testosterone, but what they do is they just don't allow the testosterone to touch the cancer receptor. So it's very precise. So it's part of, being precise in terms of your oncologic care. And we do a lot of that now, but we often combine it with the primary agents like Orgovix or injectables called LH-RH agonists called Trelstar and Lupron, because that's where these newer agents, we don't have the data to say that they're super sensitizers as Orgovix or Trelstar. So we still have to go with that. Otherwise, we're kind of making a leap of faith. Okay. Yes.
That leads perfectly into my question. So how do you know that the hormonal therapy is at its pivotal effectiveness? How do you check that?
So she's asking, how do we monitor hormones? Well, generally speaking, the best way to monitor is checking your PSA. So we would expect, the PSA to drop like a rock once you've initiated hormones. Okay, and that's what we do. Okay, it's primarily a biochemical, a biomarker issue. There are other markers like prostatic acid phosphatase, which also should go down, and but PSA is the best way to determine that. Okay, well, I think that concludes our Prostate Cafe session, and we'll be doing this again next month. Thank you for coming.